And thank you. And thank you for the Focus Initiative. We have got to establish new paradigms to pay for these drugs. It is going to be in some way an interaction with folks such as you and folks such as me. That interplay in which great ideas are channeled into legislation which will hopefully bring the benefit of these medications to others. And a little bit more about myself. I spent, and I only say this because it's critical to my perspective. I worked for 25 years in Louisiana's public hospital system for the uninsured. And when you're in a hospital system for the uninsured, you recognize that there are budgets. And you also recognize that there is a portion of our fellow Americans for whom not everything will be lavished, but rather they are going to be queued up in terms of their access. And I just lived that for 25 years. And that informs everything I think about when it comes to health care. So if the goals of health care reform are access to affordable, quality health care, or in this case, drugs, I think what we're speaking of today, in order to facilitate access, is that things must be affordable. It must be affordable. And by the way, you got to consider cost up front. And Mark Trustman and I have a little bit of a disagreement. We had some go back and forth as I sent him my remarks, and he said this and that. And I think we cannot be too sanguine about upfront cost, however we choose to pay it over time. Because again, working as a doc in a charity hospital system for the uninsured, both in California and Louisiana, I found that if you don't consider cost up front, then you must tacitly be agreeing to unlimited taxes or to unlimited premium increases or to economic rationing. And that is a reality. By the way, and we can say, well, this is medications, it's not docs, it's not hospitals. When you go to a state Medicaid budget, and state Medicaid budgets are cannibalizing the rest of state budgets, what happens if you're paying more for medications? You're decreasing reimbursement rates for physicians or for the managed care company, and therefore fewer and fewer physicians will see such patients, and therefore they have less access to the person who shall prescribe these life-saving medications. And I'm going to go, so with that preamble, I'm going to also kind of illustrate how I'm going to approach this talk, which is to use sickle cell anemia as a case study. We're on the cusp of having gene therapy for sickle cell. In a state like mine, we got lots of sickle cell patients. And so I kind of used thinking about that as a way to go forward. One more thing I want to stress is that the choice is not between paying whatever the company decides to charge for the medication or denying access to a life-saving drug, but a middle way which in some way establishes a cost society can afford and a means which facilitates paying that cost and at the same time rewarding innovation and making sure there's access. So I propose that we have a three-pronged approach for approaching the situation. Establish a reasonable opening price for medication, have value-based purchasing with value-based purchasing robustly understood, and I will elaborate, and then a way in which to socialize cost. So, and underneath that, I would say, and Jonathan alluded to this, consider alternative financing mechanisms. Alternative financing mechanisms. First, let's talk about establishing a reasonable opening cost. I do think this is incredibly important. Let's just take sickle cell. I mean, if you've ever treated a sickle cell patient and you imagine you have a gene therapy which can heal them, it would be immoral not to give it to them as quickly as possible. It would be immoral because it just how it wrecks their life and destroys their future earning potentials. But unlimiting pricing is not sustainable. So you come up with a gene therapy which is immoral not to give. What could you charge for it? Well, we know the avoided costs. We know somebody by age 45, it's estimated will consume about $1 million worth of cost. Okay? Should you charge $1 million for it? Could you charge $2 million? Because there's a certain moral capacity to this. Well, you could, okay, but I think we need to go into that a little bit more deeply. First, sickle cell affects, according to CDC, 90,000 to 100,000 Americans. 90 to 100,000. For an average person, I mentioned that sickle cell anemia will cost $1 million in lifetime cost, but that is if you cure. The only way that gene therapy affects that is if you give that to the human being when they're either in utero or right after their birth. If you give it to them when they're 45 years old, you're not going to make a difference. They already have the multi-infarct dementia, or the congestive heart failure, or the necrotizing bone disease. So you can make sure that their cell no longer sickles, but they will die a month later from congestive heart failure, because that is what is not currently reversible. And you can say, oh, this is a theoretical. It is not. If you look at the rationale for Gilead to price their treatment for Hep C, which was not a one-time treatment, but a very good treatment, it was how much does Hep C cost over time? I will point out the literature prior to that showed that the eradication of Hep C using interferon did not, on average, prolong life. Think about that. Curing Hep C did not prolong life, which tells you that there's a whole group of Hep C patients who will die with hepatitis C, but not die because of it. But nonetheless, Sovaldi had a rationale, or Gilead had a rationale for what they charged, and society bore that cost. And at some point, the VA contracted for a lower cost, but the whole predicate was that you would prevent the complications that would result from untreated hepatitis C. But I happen to know, quite personally, because I knew the person who was doing this, at the end, Sovaldi was being given to VA patients who had Alzheimer's disease. Now, they had lived with their hepatitis C for 50 years, had a benign liver condition. They were going to die from Alzheimer's, but we spent $30,000 to eradicate their hepatitis C. We could end up giving sickle cell gene therapy to someone with stage 4 congestive heart failure who's going to die within a year from congestive heart failure, and we might spend $1 million on it because statistically that's what we would save if we treated them when they were in utero. There needs to be a robust understanding of the nuances of the disease. And let's imagine, though, because this is why I think cost up front is so important, let's imagine that we have somebody right out the gate, and the newest competitor with a Hep C gene therapy is probably 1 or 2 years down the road. And they decide to charge $1 million because that is the avoided cost. I looked up a statistic. There's over 4,000 sickle cell patients in the state of Florida. Now, if you charge $1 million for each one of those patients, I think my math is right, that's $4 billion for a Medicaid program which has an overall cost of $20 billion. And that's quite a leap. And then let's think what the development cost might be for a sickle cell gene therapy. Let's say it's $500 million to get it all the way through the process and begin to inject. But you have 100,000 sickle cell patients in the United States. And if you charge $1 million per treatment for 100,000 people, wow, you just had an incredible return on investment. So we do wish to encourage risk-taking, and we do wish to reward that which is going to make people's lives better, but we also have to wonder, can society really afford 100,000 times 1 million, understanding that some of these 100,000 patients, they will have irreversible disease related to the sequelae of sickle cell anemia, but curing their sickle cell anemia will not address that sequelae. So I do think that upfront cost must be considered. And that leads us to the next thing, which I've I think, built the case for. The need for so-called value-based purchasing. I've already mentioned using sickle cell. One way to establish an outcome is whether or not you can take a red blood cell which sickles and keep it circular. That's one way. But that's not really value-based purchasing. It is, can we prevent the sequelae of sickle cell anemia? And I do think there has to be that kind of robust understanding, so that if we give this life-changing gene therapy to someone who's already got necrosis of his hips because of infarcts to his joints, that there be some diminution of payment, because we realize we've not really avoided the cost, because now we have to replace his hips. I think you see what I'm developing. And it will take that sort of calculation to make sure that this works well. Now, then I will say we need to socialize the cost. And my bias is to socialize as broadly as possible. Knowing that you've thought about this, I'm going to tell you my thoughts so you can see the inadequacy thereof and bring your thoughts to me so I can hopefully translate them into the legislation that will affect the change. One, we can have insurance pay for it. But the problem is insurance companies change. I've got Blue Cross Louisiana, but maybe next year I have United. And so would Blue Cross really want to pay for this upfront cost? And we've been speaking of sickle cell, of which the consequences are immediate. But let me take another condition. I'm a hepatologist. That's a liver specialist. When I say hepatologist, people think I'm speaking about venereal disease or snakes, and so I usually say liver disease. But there's a condition called alpha-1 antitrypsin deficiency. And alpha-1 antitrypsin deficiency, you're born with it, genetic. If you're a homozygote, both genes are abnormal, you're going to have liver disease or lung disease somewhere in your teens, 20s, or 30s. But it is in your teens, 20s, and 30s. If you're diagnosed when you're 5, the insurance company could plausibly, justifiably not pay for it and hope you'll be on someone else's plan when you're a little bit further down the line, because this insurance company, the benefits will not accrue to. By the way, if you have in alpha-1 antitrypsin disease, if you have one normal gene and one abnormal gene, then your liver disease may occur when you're 60. Well, you got a whole long time for somebody to pass to somebody else's insurance company. At what point are we going to mandate that therapy? That's something for us to consider. And by the way, insurance companies make money by managing risk, but also avoiding risk. And who here does not think that the average insurance company is not using data brokers or some information they get from Facebook or Google in order to assess those whom are their beneficiaries? We would be naive to assume that they do not. So I'm on there on Google, and I'm searching for alpha-1 antitrypsin disease, and then I pop up as a member of a small group, and I'm going to get insured, and the company kind of does their background on me. Oh my gosh, this person has alpha-1 antitrypsin disease. And we can look through our claims data, and we can see that we actually paid for a relative of him, of this person, to get alpha-1 antitrypsin liver transplant. Whoa, now we're really into territory. We almost need a unifying theory of today's society to answer this question if we're going to lay the burden on an insurance company. I would argue we need that same unifying theory if we're going to lay it on several insurance companies, because several insurance companies all would want to dodge the risk. And I think they have the capability now as they never have before. The second issue is that there's some diseases which are relatively isolated to Medicaid. Think in my state, Mark Trushman and I have worked, and Jonathan Gruber referred to some work we did that's being implemented in my state on the subscription model, or so-called Netflix model, for the treatment of hepatitis C. If you look at and this will benefit our Medicaid population and our prison population. Now, in our state, the Medicaid population doesn't really percolate that much up into the privately insured market, and inmates are more likely to come out into the Medicaid population, not into the privately insured. So if there is a condition that is disproportionately in the Medicaid population, do the commercially insured pay as well? Maybe so, but just something for us to consider as we are at the outset of this. Now, one model that I had a thought is if you think about the National Vaccine Injury Compensation Program. A child goes in and gets multiple vaccines and later has a side effect. We don't know which company did that. We don't know which vaccine that side effect is related to because multiple were given at once. So what has been set up is there is an excise tax on every dose of vaccine which goes into the vaccine injury program. And so if a child gets multiple vaccines with a Guillain-Barré reaction afterwards, then you have pooled the money which would then go to pay that claim. Would we want an excise tax on, by the way, just for the record, at this point I am the academic merely proposing ideas, I'm not endorsing any one of them, just for the record. But would we want an excise tax on every prescription that would then go into a fund that would then pay for whatever high cost, oops, my gosh, that high cost that came down? The pro and the con is that this could set a ceiling on the amount available to pay for these high cost treatments. That could be a pro or that could be a con. And that's why we truly need to think through these paradigms. Another idea I had was the main invisible high-risk pool. I think you're probably familiar with this, but in the main invisible high-risk pool, say Blue Cross Maine signs up a bunch of people. There is predetermined 10 high-cost conditions that if you have one of those high-cost conditions, you get a supplemental payment from the invisible high-risk pool. This supplemental payment is financed by a premium tax upon all insurance plans sold within the state. It goes to this. So if you're diagnosed with prostate cancer, then Blue Cross Blue Shield Maine keeps you within their disease management program. That's the important thing. You still have access to their provider network. That's the important thing. But you are hedging the cost for Blue Cross Maine because they say, I have a prostate cancer patient, and the fund in turn pays a little bit of a payment. So I've got a patient who's got sickle cell anemia. By the way, this has been predetermined to be a carve-out in terms of the therapy for this, and so there is a little bit of a something on all premiums in the state in order to pay that. That would be another way to socialize. I like that because you remain within, there's still a little bit of skin in the game for the insurance company at the high end, so they're still going to have a center of excellence, giving the treatment wherever you would have the biggest, the most possible benefit. I think that's really good. And then last is to potentially just carve it out. If you've got sickle cell anemia, the taxpayer is going to pay for it. And again, the pro and the con, as you're aware, it might be that monopsony power of the government would end up paying too little, or it could be that there was legislative or regulatory capture, and we would end up paying for that which was of minimal benefit or paying too much for that which of marginal benefit. But that's for us to work out. Now, I will say, however costs are socialized, I do think there will be a role for alternative financing mechanisms. I feel, since I have some Massachusetts people here, I feel a little bit like Elizabeth Warren swigging a beer right now. So, but I'm not running for president. I do think that there will be a need for alternative payment mechanisms. Mark mentioned the so-called subscription model, the Netflix model, where if you want to watch every episode of the Planet of the Apes and you only got a weekend to do it, you can watch them all. But it's really your risk. If you decide to take a break and you fall asleep and you don't finish the episodes, well, you lost. So what we've done in Louisiana, put out an RFP in which we have gone to the 3 companies selling drugs for Hep C, and they will give us X number of prescriptions unlimited prescriptions over a certain period of time, and we will go to our vulnerable populations in Medicaid and in the incarcerated population and treat as many as possible. So that is one model, and Washington State is now requesting that. But what is another possibility? Now, by the way, the pro of that is the cost can be lowered and amortized. The con, depending on the model, it may allow higher prices to be charged than otherwise would be charged and or backload expenses, which merely delays payment. Think the Illinois pension system. The other model, which has some of the same pros and cons, is the mortgage model. I had actually proposed this for Hep C, and Mark and Peter Bach, our collaborators, didn't care for it. But in the mortgage model, if you look at, I'm a hepatologist, as I mentioned, and I could pull down what Medicaid was roughly paying for all the complications of Hep C, and I could pull down the prevalence of Hep C in my state's prison population, Medicaid population, and guesstimate it. And then I could, the guesstimated incidence of cirrhosis, complications of cirrhosis, and liver cancer, which only results from cirrhosis, and we could put in a cost for that. And we found, the young woman working with me, Genevieve, we found that if you treated a certain percent of patients, you save direct medical cost by treating as many people as possible. And we financed that over 30 years, and we calculated, we knew after 12 years the price would fall because of generics, and after the first generic, the second year after that price fall, it falls again, and we calculated that in to come up with a payment that would go to the company. Now, I mentioned that Mark and Peter didn't like that, and we ended up going with the Netflix, but I say that because the mortgage payment model is another possibility, particularly when something like cystic fibrosis, Hep C, or sickle cell, you have a lot of good historical data as to how much that will cost. But again, once more, it does defer payments, may inflate cost, and the unanswered question would be the basis for calculating your savings. I use Medicaid because that's what my population was. Now let me finish by saying the principles I think that, again, Mark and I have talked about, and I'll credit him for this, but I think are embedded in my prongs. We have to ensure appropriate value setting, we have to encourage financial innovation, and we have to fairly distribute the burden of payment. And so let me conclude. I thank you again. It's going to take this sort of thought that will begin to change the paradigms as we enter a period where $80,000 for a drug which was sticker shock once is now going to be no big deal, because now we're talking about $500 million for our treatment. That is something. That is your role as fellow Americans to inform folks such as I to make this appropriate decision. The focused multi-stakeholder collaboration is like the example of what we should be doing. I thank you for that. And I'll finish by saying this. This is ultimately about the future of our country, but also about the future of many individuals. Since I worked for 25 years trying to bring health care to those who otherwise would not have had, I appreciate your efforts, because I like to think that what we're doing in partnership today is merely a continuation of that effort by other means. Thank you very much.